Hello, I am Kristen Madison, Associate Professor of Obstetrics and Gynecology at Women and Infants Hospital and Warren Alpert Medical School of Brown University in Providence, Rhode Island. This is lecture 3 of 3 mini lectures for the flipped classroom session on abnormal uterine bleeding. I want to thank ACOG for inviting me to develop these materials for the 64th annual clinical meeting. In this section, we'll be talking about 2 separate things. So we'll be talking about acute uterine bleeding and its treatment, and then specifically focusing on endometrial ablation as a treatment for chronic abnormal uterine bleeding. So first, starting with acute abnormal uterine bleeding. Acute AUB is an episode of bleeding that is of sufficient quantity to require immediate intervention to prevent further blood loss. Think about treatment. You have a 37-year-old non-pregnant woman who presents to the emergency room with heavy uterine bleeding for the past 12 days. On examination, her vital signs are stable, and you observe she has a moderate amount of bleeding. Her hemoglobin is 9 grams per deciliter. She's a non-smoker and has a negative medical history. Which of the following would not be the best first-line treatment for this patient? And I'm asking this question to sort of set the stage for the next slides about treatment. The options are dilation and curettage, conjugated equine estrogens, oral contraceptives, or medroxyprogesterone acetate. The answer here is dilation and curettage. So D&C is the least appropriate treatment option of those listed. Although it may decrease bleeding in a patient who's bleeding heavily and unstable, any effect is temporary. Clinical guidelines developed by the National Institute of Clinical Excellence state that this modality shouldn't be used as the first-line therapeutic treatment. And on the next several slides, we will focus on what should be the first-line therapeutic agents. The first treatment to discuss is conjugated equine estrogen. This article, Use of IV Premarin in the Treatment of Dysfunctional Uterine Bleeding, by DeVore et al., is widely referenced in reviews of abnormal bleeding and in gynecologic textbooks. Conjugated equine estrogen is proposed to build up the endometrium, thereby decreasing bleeding. Short term, it's proposed to cause small clot deposition and vasoconstriction and vasospasm of the spiral arterioles. Groups, so the estrogen group and the placebo group, were compared with respect to the proportion of patients who stopped bleeding after 3 hours, 5 hours, and 8 hours. And they found that bleeding stopped in 72% of patients who received the estrogen and 38% of patients who received placebo. Based on this study, IV conjugated equine estrogen should be dosed at 25 milligrams IV every 6 hours until bleeding stops, or up to 24 hours. Although this study addressed IV estrogen, textbooks suggest that oral estrogen is equally effective for treatment of this problem. Although using multiple pill regimens, called tapers or cascades, has been described in textbooks and commonly used for acute uterine bleeding for decades, Monroe et al. Were the first to conduct and publish a study on this treatment. This study compared a combined oral contraceptive pill taper and oral progestin with 16 women in the combined oral contraceptive group. In this study, they found that 95% of women avoided surgery in the next 28 days, with an average 3 days to cessation of the bleeding. Based on this study, the way to prescribe a combined oral contraceptive pill, taper, or cascade is giving a 35 microgram ethinyl estradiol pill, TID, for a week, then daily for 3 weeks. And the reason that this regimen is particularly useful is that it can be confusing. I know that I've been told that you can prescribe 4 pills for 4 days, 3 pills for 3 days, 2 pills for 2 days, or prescribe it differently, and that can be kind of confusing. But with this regimen, if you have patients take a pill TID for a week, they'll go through the first 21 days of active pills in a pill pack. You can have them discard the placebo pills and then start on the next pack while they're working on recovering from their likely anemia that was precipitated by their acute uterine bleeding. So a combined oral contraceptive pill, 35 micrograms of ethinyl estradiol, and 1 milligram of norethindrone, monophasic pill, TID for a week, and then daily for 3 weeks. The other arm in this trial included oral progestins. So all 17 women in the medroxyprogesterone acetate group avoided unplanned surgical intervention, and 65% stopped bleeding at 1 month follow-up, with a mean time of 3 days. Based on this study, the suggested regimen is medroxyprogesterone acetate 20 milligrams PO TID for a week, then daily for 3 weeks. And again, many other regimens are suggested in textbooks and used by clinicians are likely effective as well, but these are the ones that were studied and published. Another treatment option for acute uterine bleeding is tranexamic acid. Given its mechanism of action, decreasing fibrinolysis at the level of the endometrium, it's likely effective for acute abnormal uterine bleeding. Although it's supported as a treatment by experts, there are currently no studies for acute abnormal uterine bleeding. Also supporting its potential use, though, for acute uterine bleeding is the fact that in studies it's been shown to reduce intraoperative bleeding for orthopedic surgery and is also being used for cardiac surgery to reduce intraoperative bleeding. The way it's dosed is 1.3 grams PO TID for 5 days. So now we've concluded talking about treatments for acute uterine bleeding. Let's talk about one more treatment option for chronic abnormal uterine bleeding, endometrial ablation. Endometrial ablation was originally developed in the 1930s. Multiple methods have been developed which use different energy sources to achieve destruction of the endometrium to the level of the basalis, down to 4 to 6 millimeters. You have first-generation options, such as the roller ball and transcervical endometrial resection, which use a resectoscope method under direct visualization. And then you have second-generation non-resectoscopic methods, such as heated free fluid, which uses hysteroscopic monitoring, thermal balloon, microwave, cryotherapy, and radiofrequency bipolar. Focusing on the global endometrial ablation techniques, most studies include only heavy and regular bleeding and show satisfaction rates of 50 to 95%, amenorrhea rates of 13 to 64%, failure rates of 8 to 42%, and hysterectomy rates of 5 to 29%. Although most studies do show that women are highly satisfied after endometrial ablation. Studies have shown that there's no difference between the resectoscopic and global methods in bleeding reduction and quality of life. However, differences have been shown between the different global methods. So looking at comparisons of global ablation techniques, radiofrequency ablation has been shown to be better than balloon and heated free fluid in randomized clinical trials. First, focusing on bipolar versus thermal balloon, in a study with 10 years of follow-up, bipolar ablation was superior to balloon at 1 year and 5 years. In their publication from their 10-year follow-up data, this was no longer evident, although this is likely attributable to menopause, given the main age at inception was 43 years of age. Radiofrequency ablation has also been shown to be superior to heated free fluid. And looking here at this study, where there were 160 women who were randomized to radiofrequency ablation versus heated free fluid. At 1 year follow-up, 47% of the patients in the radiofrequency arm and 24% of the patients in the hydrothermal ablation arm experienced amenorrhea. Focusing on the 5-year follow-up data for failure, 19% in the radiofrequency arm experienced failure compared to 44% in the hydrothermal ablation arm. It should be mentioned that there are other factors to consider here as to which treatment might be superior for the individual patient beyond just treatment effectiveness, such as uterine characteristics, whether you're in the office or hospital setting, the ease of the preoperative preparation, surgeon familiarity and preference, and device availability. There may be some patient characteristics that help predict the likelihood of success and failure. And in this study, the amenorrhea rates were 23%, with a 5-year cumulative failure rate of 16%. They found that the predictors of amenorrhea in this study were patients of older age, smaller uterus, with a thinner endometrial stripe. And they found that predictors of failure were younger women with a higher parity, prior tubal sterilization, or a history of amenorrhea. They also found in this study that the use of radiofrequency ablation was associated with 2.8 times the odds of amenorrhea compared to balloon. How does endometrial ablation stack up to the levonorgestrel intrauterine system? And a Cochrane review showed that satisfaction, quality of life, and risk of treatment failure are similar with the levonorgestrel intrauterine system and endometrial ablation. There are conflicting results about bleeding reductions in the first year of use. The Cochrane review found that ablation was better at 1 year, and studies with longer follow-up had no difference. Another systematic review found that bleeding reduction was similar for both 1 and 2 years. Decision analyses have shown that the levonorgestrel intrauterine system is preferable for balancing the effect versus cost. So how does endometrial ablation stack up to the definitive management for abnormal uterine bleeding? Hysterectomy. So no surprise, hysterectomy is better for bleeding reduction at 1 year, satisfaction rates at 2 years post-op, and some evidence of improved health status such as social functioning, energy, pain, and general health. Ablation has been shown to be better for surgery duration, hospital stay and recovery time, most adverse events, and overall costs, but not necessarily cost effectiveness. It should be noted that 4 years post-ablation, approximately 1/4 of patients will have a hysterectomy. So take-home points here. This third slide set we discussed treatment for acute uterine bleeding and using endometrial ablation to treat chronic abnormal uterine bleeding. So for acute abnormal uterine bleeding, IV estrogen and multiple pill regimens of progestin and combined oral contraceptives appear effective, and tranexamic acid is also likely effective treatment for acute uterine bleeding. For endometrial ablation, there are many different methods, high satisfaction rates for patients. Radiofrequency is more effective than balloon or heated free fluid, and a similar effectiveness to the levonorgestrel intrauterine system. I hope that these 3 mini lectures on abnormal uterine bleeding have been helpful, and I look forward to meeting you at the annual clinical meeting to discuss abnormal uterine bleeding further.